The following are T2 weighted MRI images of a 57-year-old African-American female who was involved in a motor vehicle accident on 10/20/15. She was driving through an intersection when the other vehicle crashed head-on into the passenger side door. She was belted and the airbag deployed, compressing her chest. She was going approximately 30 miles per hour while the speed of the other vehicle is not known. She was taken to the ER at BGH. Her chief complaint was of chest pain followed by abdominal pain. She did not report neck pain, headache, loss of consciousness, or nausea vomiting. Initial chest x-ray indicated cardiomegaly and possible mediastinal widening. Same-day CT torso confirmed mild cardiomegaly and ruled out mediastinal hematoma. No rib fractures or dislocations were indicated. There was a tiny right-sided pleural effusion. CT of the cervical spine and abdomen did not indicate any acute post-traumatic abnormalities. EKG indicated sinus rhythm with occasional PVCs. Blood pressure was elevated to 226 over 143 at 76 beats per minute. Glucose was 135. CBC, CMP, and coagulation studies were within normal limits. Amylase and lipase were within normal limits. eGFR was greater than 60. Follow-up with her primary care and consulted cardiologist detected persistently elevated blood pressure above her baseline elevation and required upward titration of metoprolol and lisinopril on 2 separate occasions due to lack of control of systolic blood pressure in the 170s. Currently, per patient, it is now under control. At this visit, she also noted persistent bilateral neck, right shoulder, and mid-back pain, as well as bilateral pain and paresthesia in her upper extremities. This pain has prevented her from carrying out her duties as an administrative assistant, which involves work at a computer station. She is currently on leave of absence from her job and hopes to return to work soon. She was referred to a neurosurgeon who ordered cervical and thoracic MRIs, which detected an ascending thoracic aortic aneurysm as an incidental finding. The studies were conducted on 11/23/15, approximately 1 month after the accident. The patient has no known drug allergies. Her past medical history includes chronic hypertension and hyperlipidemia. Past surgical history includes a loop electrosurgical excision procedure in 2014. She is currently taking metoprolol, lisinopril, atorvastatin, cetirizine, and hydrocodone acetaminophen. She is a non-smoker, a social drinker, and she denies illicit drug use. Non-contrast MRI at the C2, C3 level. Here, it's normal. This is your annulus fibrosus. This is your nucleus pulposus. The whole thing is the disc. This is the spinal canal. This is the spinal cord. There are no disc bulges, and there is no herniation. And the neural foramina are patent. The C3, C4 level is normal as well. C4, C5 level shows concentric bulging of the disc without evidence of focal disc herniation or central spinal stenosis. The neural foramina are patent. Average ranges of cervical canal diameter are from 23 millimeters at C1 to 15 millimeters at C7. C3 to C6 is usually about 17 millimeters. This is in the anteroposterior diameter, and stenosis is classified as relative stenosis between 10 and 13 millimeters, and absolute stenosis is less than 10 millimeters throughout the cervical spinal canal. So you can see the concentric bulging in the sagittal plane here. And you can see some thecal sac compression here. The thecal sac is made up of the dura, and it's filled with cerebrospinal fluid here. But there is no focal disc herniation, meaning there's no nucleus pulposus protruding through the annulus fibrosus. C5, C6 level shows concentric bulging of the disc without evidence of focal disc herniation or central spinous stenosis. The neural foramina are patent. It's very similar to the above level. You can see the bulges in the sagittal plane, and you can see some flattening of the thecal sac here, but no evidence of herniation. C6, C7 level shows concentric bulging of the disc and ventral disc herniation without evidence of disc herniation into the anterior epidural space. The neural foramina are patent. What this means is there's a ventral disc herniation here and here, but it does not go backwards into the anterior epidural space and does not compress the spinal cord or cause spinal stenosis. The C7T1 level is normal. The cervical cord is normal. There are no hyperintensities or areas of brightness or whiteness within it, indicating a lesion. There are no fractures or dislocations in any of these vertebrae here. These white lines across here are veins. This image demonstrates a thoracic aortic aneurysm, possibly traumatic. A thoracic aortic aneurysm is one that is greater than 4 centimeters of any part of the thoracic aorta. It is due to stretching and tearing of the intima, media, and adventitia and must be bound by all 3 layers to qualify as a true aneurysm. Anatomically, aneurysms can be subclassified into ascending, descending, or arch aneurysms with respect to the thoracic aorta. Morphologic subclassifications include fusiform aneurysms, which are full circumference and symmetric, as well as saccular aneurysms, which are localized asymmetric outpouchings. Most thoracic aortic aneurysms do not produce symptoms. If large enough, they can compress the trachea, esophagus, and recurrent laryngeal nerve, resulting in respiratory symptoms, dysphagia, and hoarseness, respectively. Ascending aortic aneurysms in particular can also cause aortic regurg and lead to congestive heart failure. Thoracic aortic aneurysms can be produced by compression, deceleration, and blunt trauma of the thorax, which do not fracture ribs necessarily or bruise the chest wall. Motor vehicle accidents, the most common etiology, often result in both compression against the steering wheel and rapid deceleration. Differential rates of deceleration result from varying degrees of attachment to the spine, other connective tissues, and the heart. Vertical falls, airplane crashes, and crush injuries also result in such rapid deceleration. It has been postulated that these differential rates of deceleration put a net force on the aorta, most notably at points of fixation. Torsion and shearing forces build up at the ligamentum arteriosum, aortic root, and diaphragm, which are relatively fixed. Common sites of post-traumatic thoracic aortic aneurysm include just distal to the left subclavian, where the ligamentum arteriosum attaches, and in the ascending aorta, just distal to the aortic valve. Direct compression of the heart and/or aorta can lead to increases in intravascular pressure. This so-called water hammer effect can cause rapid dilation and transverse tears, most commonly at the level of the isthmus and aortic root. Whatever the dominant mechanism, the pathophysiology is complex and likely due to a combination of these mechanisms. Some individuals have weaker and or less elastic aortic walls due to congenital or acquired predispositions and are more susceptible to thoracic aortic trauma. These conditions include, but are not limited to, advanced age, atherosclerosis, smoking, hypertension, Marfan syndrome, Ehlers-Danlos syndrome, fibromuscular dysplasia, cystic medial necrosis, syphilis, and other vasculitides. Loeys-Dietz syndrome, Takayasu arteritis, Turner syndrome, and a bicuspid aortic valve are additional risk factors. MRI and computed tomography are approximately equivalent in the sensitivity and specificity with respect to assessing thoracic aortic aneurysms. MRI, however, is preferred due to lack of ionizing radiation and its ability to visualize the aortic root and the arch vessels with greater clarity. In emergent situations, however, it is impractical to spend the time to get the MRI when the CT is so much faster and just as reliable. In both MRI and CT, tortuosity must be corrected for, as it can overestimate measurement of the diameter. This is done by taking measurements in oblique planes orthogonal to the aorta. The measurements here and here, this one is 4.15, which is greater than 4 centimeters and qualifies as a thoracic aortic aneurysm, is at an oblique plane, but it's orthogonal to the aorta itself, which avoids overestimation of the diameter of the aorta. Thoracic aortic aneurysms increase risk of dissection, rupture, and thromboembolism. Must be monitored at the least and require surgery in more severe cases. Current risks of rupture per annum are estimated at 2% at less than 5 centimeters, 3% at 5 to 5.9 centimeters, and 7% for 6 centimeters or greater. Risk of rupture is dependent on age, position, size, rate of progression, etiology, sex, and comorbidity. A recent study indicated that women were at greater risk for rupture than men. Treatment is determined based on the location, size, rate of progression, and comorbidities of the patient. Relatively stable aneurysms are managed medically and monitored with serial imaging. A follow-up MRI should be conducted at 6 months after the initial imaging or at the time of symptom development if this occurs earlier. If unchanged at that time, the interval can be extended to 1 year. Expansion merits a decreased interval and is dependent on rate of expansion, etiology, and comorbidity. Control of blood pressure is emphasized, and beta blockers are the primary agent used to target blood pressure in the 105 to 120 millimeters of mercury range. Other antihypertensive classes should be added if the target is exceeded. Primary care should communicate and coordinate with the patient's cardiologist. If greater than 5.5 centimeters, surgical repair or endovascular stenting is indicated. Mortality and morbidity rates are high and fluctuate based on type and comorbidity with respect to aneurysm. Open surgical repair of the ascending aorta requires cardiopulmonary bypass. Arch replacement carries a high risk of brain damage due to embolization and global ischemic injury. Descending aneurysm repair can cause paraplegia due to ischemia of the spinal cord. All open procedures usually entail aneurysmal resection and replacement with a Dacron or polyethylene terephthalate or another synthetic tube graft. A less invasive option is endovascular placement of an expanded polytetrafluoroethylene or EPTFE, nitinol, or Dacron graft. Access is gained through the femoral artery and advanced via catheter until deployed. It carries lower risk than open surgery, but complications include most commonly attachment failure and device failure, resulting in rupture. A limited study published in 2012 of 106 patients who had aortic repair between 1995 and 2007 showed similar 10-year survival rates between TEVAR and open aortic repair, as well as lower perioperative complications. It also reported that TEVAR grafts resulted in an initial decrease in size of aneurysm followed by stabilization. Includes traumatic aortic dissection. Lack of visual evidence of an intimal flap or double lumen rules out dissection. The etiology of the aneurysm is most likely due to both trauma and chronic predisposition, to be discussed below. Ascending thoracic aortic aneurysm is one possible sequel of rapid deceleration injuries and the water hammer effect like those experienced during airbag deployment during an MVA. The patient is a lifetime non-smoker, which is a significant risk factor, and she does not have apparent connective tissue disease or a family history of such disorders. Temporal considerations. The visual evidence is indisputable, yet the etiology is less certain and most likely multifactorial. Chronic hypertension and hyperlipidemia can weaken vessel walls, creating a predisposition to vascular injury secondary to acute deceleration and chest wall trauma. The initial chest CT on the day of the accident did not detect an ascending thoracic aortic aneurysm, indicating recent post-accident development. The chest X-ray was indicative of borderline mediastinal widening. There are no cross-sectional chest images prior to the accident for comparison of the aortic diameter. The fact that there were and currently are no compressive symptoms such as dyspnea, dysphagia, or hoarseness is not helpful in elucidating the etiology, since most thoracic aortic aneurysms, traumatic or otherwise, are asymptomatic. Considering the mild cardiomegaly was present at the time of the accident, it is unlikely that the aneurysmal dilation, if acquired at the time of the accident, contributed to the cardiomegaly. This is important because thoracic aortic aneurysms can contribute to the development of heart failure. The sharply elevated blood pressure discovered after the accident may be due to emotional stress due to the patient's pain symptoms and uncertainty about her ability to return to work. Irrespective of the cause, this elevated blood pressure most likely contributed to development and or worsening of the aneurysm and needs to be monitored closely to avoid rupture. The most likely scenario is that the aneurysm is a result of the acute trauma of the motor vehicle accident and the underlying conditions of the chronic hypertension and hyperlipidemia. Continuing with the thoracic spine, the T4, T5 level shows concentric bulging of the disc and a ventral disc herniation without evidence of disc herniation into the anterior epidural space. The neural foramina are patent. Here you can see that the average size of the thoracic canal is 12 to 14 centimeters relative to the larger cervical canal, which you can see here and here. The larger cervical canal is between 23 and 17 millimeters. You can see the ventral disc herniation here. There are also some osteophytes, but the herniation does not go into the anterior epidural space. The T5, T6 level shows concentric bulging of the disc and a ventral disc herniation without evidence of disc herniation into the anterior epidural space. The neural foramina are patent. This scenario is very similar to the above disc level. Again, you have herniation ventrally, but not posteriorly into the anterior epidural space, and you have some herniation here of the nucleus pulposus with this increased signal intensity, and you also have osteophytes, which are black because the bone is black. It's also known as an osteophyte disc complex. All right.